Ian, thanks very much for asking me to come and speak about this. I have a role as the chair of the Society for Cardiothoracic Surgeons in Great Britain and Ireland database committee, and I've been involved a little bit more recently with the recent EACTS report. The UK agenda is relatively mature. We've been collecting data since 1977, and then slightly more sophisticated data since 1994, and that's really all been down to Bruce Keogh taking this up and running with it. And our most recent report came out in August last year, and we got 400,000 patients in that. And obviously we deal with patient characteristics, operative details, trends, post-operative outcomes, and we've tried to move away from just looking at mortality, which has been our index indicator of quality, if you like, to looking at complications. And we have the ability through our system to track long-term mortality through the UK Office of National Statistics. So we've generated survival curves on that. It was an interesting thing to do, but quite a frustrating thing to do in a way, because what we did is we produced, as best we could, a whole bunch of univariate analyses. But every time you were writing any little bit of it, you just wanted to have a team of analysts and epidemiologists enabling you to dig deeper into the whole thing to get a true understanding rather than just a superficial take on it. For anybody who's interested, that's available on the web, or it was available from Dendrite Clinical Systems, who were responsible for producing the report in conjunction with us. The current initiatives that we've got going on, I think, are around public reporting, about a national governance process, about how we're taking the data collection to support local quality improvement, and how we're trying to develop some academic endeavours around it to dig deeper to answer some hypotheses on this. And the one thing that we've got as a major agenda item in the UK, and this is for all medicine, not just for cardiac surgery, is professional revalidation. Competency has always been assumed in the UK. If you pass your exams and you become a consultant, it's assumed you're competent. But now we're going to need to demonstrate that competence in a regular fashion. There's been a whole bunch of high-profile governance failures in the UK which have influenced the politicians pretty significantly. And this was the Chief Medical Officer's report from 2005, but this has now become law. So we need to use our database to demonstrate that competence, and there are some challenges around that, obviously. Our results first came into the public domain in 2001 following a an initiative on administrative data from a media company called Dr. Foster. And then a law came into being in the UK on the 4th of January 2005, and within a month of that we had all hospitals had a letter from a major national newspaper requesting their outcomes data off the back of that law. And in the UK you have to give that data within 20 days. So since that time, our results were published in the newspaper, and then we very rapidly responded to that to have a professionally led public reporting system. And that's happened since 2005 in the UK. So we now have all NHS hospitals report, and that's mandatory, and hospital surgeons can report or not as they want, and that's entirely voluntary. But if a unit wants to be in, it's all in. If a unit doesn't want to be in, it's all out. And 70% of surgeons are currently reported. Historically, that's been done by our professional society in conjunction with the organisational regulator, the Care Quality Commission, but we're migrating that away. We're copying the STS guys a little bit. They say imitation is the best form of flattery. So we're moving that away from the regulatory position to do it in conjunction with a patient organisation, PICA Europe. The kind of thing we have is the results. So that's a list of the surgeons in my hospital. It gives you the number of cases they do, an indication of their practice profile, and then the results compared to the predicted mortality. People say people aren't interested, but we get 26,000 hits a month on that website. So somebody's interested. I hit it a bit, but I don't hit it 26,000 times a month. So we have to superimpose a governance process on top of all of that, and that's been challenging for us. So all the patients in NHS hospitals are enrolled in the database, and we picked up fairly early on that the logistic Euroscore had drifted with its calibration. So the observed mortality is around 45% or so of the number which is spat out by the logistic Euroscore. So we've applied a contemporary calibration to the logistic Euroscore for the purposes of this analysis. We've had extensive iterative data validation with the units, and then we've analysed the mortality by hospital and by surgeon after making those adjustments. And we've devised a methodology to superimpose upon that for what we do when results don't seem to be quite where they should be. And I thought it might be interesting just to deal with that a little bit. We first defined some principles. We felt the process should be reasonable and proportionate. we felt that we should do everything we could to prevent the unintended negative consequences of risk-averse behaviour. We defined divergence from expected in two ways: how far away it is, and how frequently it occurs. So is it a one-off thing, or has it been a repetitive period over several monitoring cycles? We tried to make the point very clearly that if there is divergence, that doesn't mean the surgeon's bad. It means you need to look in more detail, and you need to have mechanisms both for investigating things and supporting the surgeon in the hospital when you're going through that process. And that the explanations should feed in four stages: data for accuracy, and we've had a whole bunch of issues when we found what seemed to be outliers, but that's actually been due to data accuracy issues, mapping issues, missing data, things like that. Case mix, understanding the case mix, understanding institutional factors, and then only at the end of that process might you want to be considering surgeons' performance issues. And we've accepted that policy now, and we have implemented a number of investigations off the back of it and done some learning from there. We also need to use better use of this data for supporting quality improvement. We have regular feedback of benchmark clinical outcomes, and those are available online. And we're also trying to produce a more formal reporting structure off the back of that. And in line with the STS initiative, we've also moved away from just reporting on mortality to reporting on complication rates, and also a bunch of best practice process measures as well. And we're also aiming to make this data as accessible as possible, and we're developing some methodology at the moment for a basically lookup table methodology which sits in front of the database to enable people to ask bespoke questions to support decision making, and I think that would be a useful addition to the things we do. We've got a bunch of challenges, obviously. Data quality is not perfect. Our governance methodology is accepted by our membership, but getting to the stage that we've got to has not always been easy, and it's not accepted in full by all of the membership, and I think we need to be doing everything that we can to respond to legitimate concerns around that. I think that we need to accept that you can't adjust appropriately for all cases, and we need to be thinking about that a little bit more. And I think so the way we've now sort of cut and sliced the Euroscore to make it fit for purpose makes it virtually unrecognisable from its initial published form, and I think there's some confusion around that, and I think there's a real need for having better risk models, and I'm optimistic that the new Euroscore project will give us that. One observation about that: if the Euroscore 2010 comes out soon and is a good predictor, what we do need to understand fully is what we do as quality improves in terms of calibration drift to make sure it stays fit for purpose, and we'll need to have some understanding around that. And we've got a short-term working group in our professional society to come up with some plans about mitigating against risk-averse behaviour with mandated second opinions and using the HEART team for decision-making process and all that kind of stuff. So we're trying to respond to that as well. Future initiatives: we need to evolve the data set. There was some discussion around this yesterday in the database committee meeting. The data set that we have has been locked in tablets of stone since 2003, and that's important, I think, to have some sort of stability of a data set. But it's no longer good enough for what we do now because of novel procedures, because of risk adjustment, because of operative technique changes. So we need to evolve that. And we're also putting a lot of effort into database linkage, and I just want to expand on that slightly. We use a structure which is called the Central Cardiac Audit Database, which is an encrypted system for collecting data, and that collects our sort of professional data set, and it also collects socio-economic data, and we've done some research recently looking at the influence of social deprivation on access and outcomes to cardiac surgery. We then have a bunch of other data out there: long-term mortality from the Office of National Statistics, other cardiac intervention databases, pacing databases, percutaneous intervention databases. We have administrative data, which is very good for picking up whether a readmission has occurred. We have some initiatives around collecting patient-reported outcomes, and we're doing more and more work now on patient experience measures. And because we are sort of the biggest managed healthcare system around, I guess, every patient has the NHS number, which is a unique patient identifier, which enables you to link these things up together. And what we're aiming to do is produce a composite data set. What we're doing is not in any way unique. I know the SDS guys are doing very, very similar things, and we're doing this stuff in parallel, and I've learned quite a lot from the way you've done things. But we're a long way down that route now. There's some challenges in this. There's the technical challenges of actually doing it. There's the legal challenges about patient confidentiality and complying with data protection legislation, suppressing small numbers and all that kind of stuff. There's the political challenge of working with other professional organisations and working across geographical boundaries and stuff like that. And there's the academic challenges as well, because once you have something like this, you can very easily make wrong interpretations unless you have the appropriate statistical and epidemiological expertise, and we're trying to sort of suck that all in to take this stuff forward. So the aims of this is to try and support quality improvement, so you get better patient management and also better patient access to care, so the patients who need it genuinely get referred up. To inform and drive cost-saving initiatives, which is a real big issue for us right now, and I guess it's for many people. To provide a big database to enable hypothesis testing, and we're doing some stuff around that, and obviously there needs to be an understanding how that sort of methodology fits into randomised trial methodology. I don't think it's any way antagonistic, it's kind of complementary. It will help us with understanding about the management of the disease process across healthcare sectors, so not just thinking about tertiary care or secondary care or primary care. We're using this to underpin the maintenance of public trust in the profession, and hopefully this will drive cultural change within healthcare by doing this in a more sophisticated way. People look at me sometimes in my society when I talk about cultural change like I'm completely mad, and I just wanted to expand a little bit what we're kind of thinking about that. I think there's been a big movement recently with more accessible information, patient power, the media, the internet and everything, and there's a real onus on us to provide much more patient-centred care, which I think we've historically thought we did, but I think the reality is we probably haven't done it. I think the way many people provide care is not supported by the best quality of information, and we need to do that. Tesco's don't run their business without knowing how much widgets they sell from the top shelf and the end of the aisle compared to the knee-height shelves on the side of the aisle. We need to understand that stuff much better. And this sort of brings a culture of modern medical professionalism, which I think this agenda helps to drive. And I think the other thing we found is that when you flag up that performance isn't always the same, you need to deal with it, and you need to deal with that in a way, in an active, supportive, evidence-based way within the organisation. So I think there's been a big driver for this, for change in the managerial culture as well as the professional culture. So I think there's a lot going on there that may or may not strike themes with others, but I think that's an important part of this whole agenda. So just briefly now, we produced the EACTS database report, and the aims with that was to collate as many patients as possible from the cardiac surgical registries around Europe and from members of EACTS who are outside Europe to support local clinical governance and quality improvement, and to try and identify some changes in clinical practice. And I'm not going to go this into any great detail because the copies are available for people who want them. So we've got over 1 million patients now from 366 hospitals, 29 countries in Europe and China, including Hong Kong. And we've listed all the attributions for that. Some countries have all their data in, some just have one hospital. So it's very variable, and you need to understand that before you interpret the data that comes out in the report. We've listed data completeness, which is far from perfect, but we've listed that there overtly so people can see what the data's like, and so countries who aren't submitting data which is as good as others can learn from that and try and make some changes. And we'll also be very clear, for data to get right into the book, it has to be collected right at source, the definitions have to map, there needs to be no issues of translation or transmission, and it's quite possible, and we know this is the situation in some cases, that errors in data in our report are not due to local errors of data but systems errors, and we need to learn from that to make this stuff better in future. This is just to make the point, this is the proportion of all surgery which is isolated coronary artery surgery. So in some countries it's nearly 80%, in some countries it's only 25%. That may be real, it may be artifacts of the way the data's collected, but we can't make those judgments from where we sit centrally, but people can understand that better locally. So this is the sort of the way Dendrite are looking at it, and I think they're absolutely right on this sort of concept of reveal, interpret, improve. And what we're really doing in this project is revealing, and the interpretation and the improvement needs to happen locally. And all we can do is put the stuff back out there, and hopefully people will pick up the ball and run with it locally. Just again, some sort of headline figures. This is a change in valve usage over the last 5 years, with a sort of relentless increase in the proportion of biological valves at the expense of mechanical valves, both for aortic valve and for aortic valve and CABG. This is the changes in different age groups, where the mechanical valve incidence is going down with age. And then this is for each country to show what their practice is compared to that sort of database trend. And again, I'm not making any judgments about this, but it enables people to see how they stack up and understand and think about things locally. We've also produced some bespoke reports to go back to each of the individual countries. We felt it was inappropriate to include mortality data openly in the public report because of issues about data quality, issues about validation, and also the sensitive political arguments there. So we also felt it was not appropriate not to feed that data back. So we've offered up these bespoke reports which have a more in-depth analysis of the local data quality compared to the database standard, and also crude and risk-adjusted mortality outcomes. But again, we're issuing these back to the submitting countries because only they can understand these things and implement changes as necessary. So this is just an example of the data quality for Hong Kong compared to the Asian zone as a whole and the database as a whole, and where they stand up with respect to their completeness of those data fields. And this is their mortality data with a funnel plot, and we've produced funnel plots in these bespoke reports of all cardiac surgery, isolated CABG, isolated aortic valve, combined aortic and CABG, and also we've done some risk-adjusted stuff based on the best we could do with a recalibrated iteration of the Euroscore given the data quality. So there's caveats in there, but it's better than crude data, and we've explained the methodologies that we use. So we had the X-Database Committee yesterday discussing the congenital database, the Euromax database, and we had some considerable discussion about the adult cardiac surgery database. Bruce Keogh gave a nice analogy that this is a project which has been in gestation for a while, and now the baby's been born, and we need to look after the baby better and ensure it grows and it functions well. And this has been done pretty much by the goodwill and the expertise of Dendrite Clinical Systems and some enthusiasm from some obvious individuals. And I think we need to put that on a more robust footing, and for that we need to have some resource. So I think there's agreement that we need to ask for that resource through various sources. I think there's also an absolute acceptance that we need to evolve the data set. I know the STS have done the same, the UK data set are doing the same, and we need to ensure that those developments are in synchrony and mappable, both going backwards and across countries going forwards. And we need to develop better reporting structures, both web-based and through a report structure. So I think those were the things that I wanted to bring out. Thank you very much.
Okay.